Good morning. We're going to talk about Unit 5 today, and the first chapter is chapter 25. I think it's 25 through 27. And this chapter is over seizures. So there are types of seizures: epilepsy, one who has repeated seizures or recurrence of seizures. So that's a person who has epilepsy often has seizures. They're an excessive or disordered electrical activity in the brain. And there's a description of them in your chapter where it shows the nerve cell and the abnormal electrical discharges, which then cause the seizure. Convulsions are involuntary violent spasms of the large skeletal muscles. And all convulsions are seizures, but all seizures are not convulsions. You need to know the risk factors for seizures. Those are listed on page 403. 404 are the types of seizures. There's a simple, generalized, and partial. Generalized affect most or all of the brain, and there are 6 types of those. And then there are partials, which are also called focal or local seizures. But in that chart on 404, talks about tonic-clonic, which is what we call the grand mal seizure. They're the tonic, they're the atonic, absent or petit mal, myoclonic, and clonic. And you need to know those types of seizures. And they're listed here. Partial seizures are focal or local seizures, and there's 2 types, simple and complex. And then there's status epilepticus, and that is a prolonged seizure. So some of the common causes of seizures are, of course, brain injury, degenerative disorder or dementia, strokes, idiopathic infections like meningitis, metabolic abnormalities or electrolyte imbalances, and tumors. Anything that can affect the brain and that electrical activity in the pathways can be a cause of seizures. Nursing management of seizures, you have to know the ABCs, of course. I've told many of you the airway is the most important, and so you will need to provide oxygen and have suction available, monitoring for apnea, and then safety. And I'm sure you've learned that in your skills class, but we would pad the side rails if we know they're an epileptic patient that's going to have frequent potential seizures. Remove objects that are in the bed. Turn the patient, if they're having a seizure, on their side. And those are all listed in the chapter. That is listed on 406. You need to know the before giving any anti-seizure drug, after giving the drug, any teaching you need to do. So certainly before you give the drug, you need to have a complete list of their meds, and especially phenytoin, and because that can interact with many drugs. And you need to know after giving a med, you need to certainly check their level of consciousness, their vital signs, whether they're dizzy. Make sure they have help getting out of bed, monitor them for seizure activities, etc. Certainly they don't need to be drinking alcohol, driving any vehicles. They need to wear alert bracelets, etc. So read all of that. You need to tell any surgeon or dentist that you're on medicines for seizures so that they can be protected at all times. let's see. Okay, we're going to talk about the first-line drugs for partial and generalized seizures, and Dilantin is the most common one that I can think of, which is the one that you need to always check to make sure the patient is, if they're on that, because it can cause a lot of interactions. It requires a drug level monitoring, and the adverse effect of it is Stevens-Johnson syndrome, which we've already studied about. Side effects of Dilantin are gingival hyperplasia, so they'll need to go have regular dental checkups. They need to have good oral hygiene, etc. Phenytoin and like drugs require drug level monitoring and watch for hyponatremia. So Depakote is one, Tegretol. Those are both drugs that are like Dilantin. They need to avoid grapefruit juice, etc. Types of absent seizures we call petit mal seizures. And let's see, let me make sure I didn't miss a slide. Nope. So petit mal seizures, they have a brief loss of consciousness, and they can take Depakote or Xarelto. And nausea, vomiting are caused, indigestion, decreased appetite, weight loss. So petit mal seizures, patients, you may not even realize they're having it. You may think that they're just kind of like, quote, out to lunch. They're there, but they're not in the presence with you, and you may be talking and you may think they're hearing you, but you may think they're also not paying attention. Then they could be having petit mal seizures. Adverse effect of these are listed here. Certainly a lot of adverse effects. Second line drugs are Klonopin, Neurontin, Lamictal, Luminal, Lyrica, and Sertan. These are all second line alternative drugs that patients are put on. The known side effects of those are listed on page 411. Be sure you know that. Also make sure you know that pancreatitis can certainly come from some of these medicines. And so the patient has enough to worry about. We may give them pancreatitis. Adverse effects of these are listed here. Phenobarbital, closure of the larynx, shock, respiratory depression, lots of side effects. So make sure you study all that. Make sure you know the terms. Make sure you know the key points at the end of the book. Seizures are abnormal electrical impulses in the brain. The most common ages are early childhood and late adulthood, although people who've had any kind of brain trauma can have seizures. Typical seizure consists of the aura, which is right before, and then the seizure, and then a post-ictal period. And in the post-ictal, they're kind of in a little dreamlike world. And so you need to know those three stages. The two major groups are generalized and partial. Status epilepticus is a prolonged seizure. And the exact action of most anesthesia drugs is not known. Many drugs interfere with the effects of birth control pills, so women need to be very careful if they're on those. Antacids decrease the absorption of these. Antacid decreases the absorption of many meds. You cannot just stop taking any anti-seizure med because it can throw you into a seizure. So they need to be notified of that. And if they have any changes and increased seizures, certainly they need to call their doctor. Chapter 26 is Alzheimer's and Parkinson's disease. You hear a lot on the news nowadays about Alzheimer's. They're both progressive neurological disorders that are more common as people age. So they're progressive. Alzheimer's is the most common form of dementia. Parkinson is a neurodegenerative disease, and it is slow and progressive degeneration of the nervous system. People can live for years with Parkinson's and Alzheimer's. and Alzheimer's. Those are sad diseases. It is progressive. Alzheimer's is and incurable, and it destroys brain cells. Dementia is a brain disorder that seriously affects a person's ability to perform activities of daily living. You need to know the terms in the front of this book. The presence of a protein, beta amyloid. A beta is what they look for in the CAT scan. And if they see these proteins in the CAT scan of a patient, a CAT scan of their brain, then they can predict that they either do or will have Alzheimer's. And other protein twist and form tangles within the neurons. So the proteins in the brain are what they have finally found are what causes the Alzheimer's. And then your age, genetic, if you're Down syndrome, head injury, smoke, high blood pressure, high cholesterol, certainly genetics plays a role in Alzheimer's.
You get to the stopping point your mother's calling you.
Sorry, I may have gotten interrupted there for briefly, but we're talking about Alzheimer's, and of course it's impaired mental, memory and judgment, confusion, disorientation, certainly aggression occurs, depression, and the early and late stages are listed on page 418 of your textbook, and certainly the beginning is forgetfulness. They can't remember some simple things, remember parts of their job that they were doing. In the middle, they're beginning to have a difficulty speaking, understanding. They may not recognize their family members. Simple tasks such as combing their hair. And I remember an early patient of mine didn't know what a hairbrush was, and that was my first as a new nurse, thinking I just didn't really understand Alzheimer's like we do nowadays, but she didn't even recognize what a hairbrush was. And then late, they get aggressive, need total care, they wander from home, they often turn against their family members, so it's a horrible disease. This beta amyloid protein right here is what we're talking about, what they look for in that CAT scan. Management, there is some, nowadays there's no cure. Certainly the Aricept is one that people normally take, and it has side effects, but not too bad, but it intensifies the effect of acetylcholine and improves activities of daily living, behavior, and cognition. And Namibia is another one that is given. You need to know the adverse effects in teaching, what you teach before and after. Adverse effects, certainly, of this, it can cause, it's in the common side effects in the side of your textbook. Nausea, vomiting, dizziness, headache, fatigue, drooling. If they have overdose, they may have upset stomach, vomiting, drooling, sweating, slow heart rate, bradycardia. That's overdose. Because you remember these patients are sick, they're elderly, they're not metabolizing medicine as fast as they should be. They may be a kidney patient, a renal patient, a pulmonary patient, and with that comes the effects of these meds build up in their system, and so you really have to watch for these overdose symptoms. If you, before giving a drug, you need to obtain a baseline weight and blood pressure and heart rate and rhythm, and ask about all the weight loss and nausea, vomiting, if they've had any of that. Any urinary output issues. Check their hemoglobin and hematocrit levels before giving these meds. Assess their swallowing because the patient may be at risk for aspiration, and so you need to check their ability to swallow. Do not crush these medicines, and certainly look for liver and kidney previous history that we've talked about. Parkinson's disease is another serious motor symptom it has motor symptom and non-motor symptoms. And it is progressive disease. The first thing you usually see is someone who has tremors of hands and head at rest, muscle rigidity, then it becomes stiff. They can get a poker face, difficulty moving their limbs, bradykinesia, that is difficulty swallowing, chewing, or speaking. They then start shuffling their feet. They have difficulty with fine motor skills and their posture. They're hunched over and they lose balance. They fall. Had a very good new friend that lived down the street from me that was developing Parkinson's, and she was classic at all of these signs and symptoms. She started out with tremors of her hand. She was an artist. Tremors of her hand, and then had a lot of trouble with her feet. She was an avid walker around the neighborhood. She started having problems walking, falling, difficulty with her fine motor skills, so she had to give up her artistry, and then we would find that she had fallen in her house. So she literally had this, and it was progressive. So what happens is these brain nerve cells near the base of the brain, in the substantia nigra, it contains the cells that produce dopamine. And dopamine acts as a transmitter between the nerve endings. And so dopamine, they have found, is the culprit of this Parkinson's disease. And so it's a imbalance of the dopamine between the transmitter of the nerve endings that causes the problems. We talked about the major symptoms with my friend. The drugs that cause secondary Parkinson's can be compazine, antihypertensive called Serpacil, antipsychotics, or numerous antipsychotics that can cause Parkinson's. And Reglan is a GI motility drug, and Reglan is a very popular drug that is given nowadays. And it can cause secondary symptoms of Parkinson's, and then certainly illicit drugs. So I said dopamine was one of the pharmacological management, and so they give dopamine agonists, and such as Parladel, Cinnamate, Mirapax, Requip, Apokyn. I mean, they're coming out with new ones all the time, and they help increase the dopamine activity in the brain. So there's lower dopamine activity in the brain, and that is what they have found that is causing this. Make sure you read on page 420 the drug alerts for the meds for Alzheimer's. I didn't mention that. And on page 422, you know all of the symptoms of Parkinson's disease. And you've studied the memory joggers there on the left. And another symptom of patients with the tremors, they have what they call a pill rolling tremor. They move their hand, their fingers while at rest in what they call a pill rolling tremor. And that is a classic sign of someone who is experiencing Parkinson. So make sure, I don't need to tell you often enough to know all of these memory joggers that are on the side of the paragraphs in your book. Common drugs, those are listed on page 423, and those we're looking at right now. So the dopamine agonist and the Comtan and Tasmar, they allow a larger amount of levodopa to reach the brain, which levodopa helps produce dopamine. And MAO B inhibitors inhibit the enzyme that breaks down dopamine. So you see it's all related to dopamine in the brain. And then anticholinergic drugs, Cogentin, you know about cholinergic effects on the body. and it works against the tremors and rigidity, and it blocks those nerve impulses that help control the muscles of the arms, legs, and body. And it restricts acetylcholine, an important chemical messenger in the brain that helps regulate muscles. So anticholinergic drugs help with all of that muscle tremors and that sort of thing. Acetylcholinesterase inhibitors intensify the effect of acetylcholine and improve ADL's behavior. Donazepam is Aricept. It's a very common one that is given for Alzheimer's. And but you can have nausea, vomiting, and diarrhea with that. Don't know how that Alzheimer's slide slipped in there, but don't let that confuse you. That's talking about Alzheimer's. I'm not sure how that got in there. Common side effects of drugs for Parkinson. We've talked about, anticholinergic drugs. If you don't, you need to. Remember, they cause blurred vision, constipation, everything dries up, dry eyes, dry mouth. Levodopa causes that dyskinesia, that disability to swallow. Commit inhibitors, dystonia, and sleep disorders. Dopamine agonists, chest pain, dyskinesia. MAO inhibitors, confusion, dizziness, hallucinations. I cannot tell you enough that you need to know that. Look up Tasmar and make sure you know that. Requip, make sure you know that. Cinnamate, you give it twice daily, and you need to avoid crowds. Understand why, and it has to do with white blood cells. Because many of the side effects of these meds cause neutropenia, and neutropenia is a decrease in white blood cells, so they can get a lot of infections. They need to stay away from crowds, etc. The commit inhibitors cause rhabdomyolysis, and that is a destruction of the skeletal muscle. So, and they cause dark-colored urine. So you need to really read these pages 422, 23, 24, 25. You are going to have test questions on those pages, I can assure you. Know the adverse effects, no teaching before and after, no lifespan teaching. In other words, the elderly are at higher risk for adverse effects. You need to know the signs and symptoms of adverse effects. That's on page 425. And foods to avoid when taking MAO inhibitors, which is on 426, such as aged cheese, avocados, bananas, figs, beer, dried sausage, a lot of that, I'm trying to say, processed foods that are like sausage, what am I trying to say, not pickled, but seasoned, red wine, salami, yeast extract, yogurt. So all of those, if they're taking an MAO inhibitor, they need to be careful with those, that kind of food. So Alzheimer's disease and Parkinson are both progressive neurological disorders. There's no cure, and Alzheimer's is the most common, and it has to do with cognition. And Parkinson is more of the neurotransmitter in the brain causing mobility issues. And you know the major symptoms, the goals, certainly is to reduce any kind of harm to the patient, and patient safety is of utmost importance. I have had friends that have had both of these problems as well as seizures, and over the years have taken care of many patients who've had seizures. And the older I get, the more I see that my friends are, some are getting Alzheimer's. And it's a very serious, very, very sad disease. Sad, especially for the healthcare giver, the wife or the husband who's having to take care of this. And I'm recording this in 2020, And we see now we're in the middle of a pandemic, and so often our loved ones have family that have Alzheimer's and they're in long-term care facilities. And as you know, they've not been able to see their family, be with their family. I know one gentleman whose wife he just got to see the other day, and she's been away from him since April. She's in a facility, and so very, very sad disease for family who are also the caregivers. So we don't want to forget about them. And as a nurse, you need to keep always in mind the stress and the grief, anxiety, depression, frustration that comes with being a caregiver and what all that entails. And that will move us to our last chapter, the drugs on for psychiatric problems, and that will be on another video.